2020, and I'm Rifat Mannan in Philadelphia, and I am remotely joined by my good friend and colleague Emilio Madrigal, who is in Boston at the Mass General Hospital. Today, we are very excited to welcome Dr. Margie Morgan, who is Medical Director of Microbiology at the Cedars Sinai Medical Center in Los Angeles. Dr. Morgan is very well known for her wonderful microbiology lectures, which are so pivotal for the CP boards. And with with the pathology boards in the US around the corner, so it would be great to have Dr. Morgan for the lectures. And Dr. Morgan also hosts a very popular microbiology website which has excellent teaching material. It's called microbeswithmorgan.com. And today she's going to deliver the first part of her two-part talk on medical mycology. The title of her talk is General Introduction and Dimorphic Fungi. As always, please feel free to post your questions and comments on YouTube and Facebook chat windows, and Dr. Morgan will be more than happy to answer them towards the end of the session. Thank you, Dr. Morgan, for joining us today. Over to you now.
Okay, thank you very much, and I greatly appreciate your invitation to speak to everyone. And today I'm going to talk about one of my very favorite topics, not COVID-19 for sure. This is mycology. I've greatly enjoyed mycology over the years, and it's really never been more important, not just in the microbiology laboratory, but also in surgical pathology. We're seeing more and more fungal disease, whether it be the systemics or some of the opportunistic fungi, as well as numerous yeast infections and unusual yeast species. So I think this will be important for your boards, as well as for your careers in pathology. I do want to say at the start that, of course, in a 1-hour lecture, I cannot cover everything there is to know about how to do mycology or about the systemic fungi. But this is just an overview. If there's topics that you're interested in, you can go to the web, to the internet or to the books to read a little bit more about the topics. Also, I am, as you can see on my first slide, I'm a PhD by training. I am not a pathologist, so please excuse me if I have a very basic discussion of the pathology of some of these fungal diseases. But I will show a lot of pictures of surgical pathology. If I am too simplistic in my approach, please just look at the pictures, maybe go a little bit deeper and read about them yourselves, because there could be a lot of the histopathology of fungal organisms on the boards, and I can assure you throughout your career you're going to see a lot of fungal disease. So let's get started this morning. And let's start at the very beginning, because I have no clue what your background might be. So let's talk about the two organisms that we do see in mycology. Of course, the first major one are yeast. They are unicellular and they bud to produce daughter cells, as the picture over on the right-hand side shows. Yeast grow very well on solid media, usually as white to beige colonies, and they look very much like bacterial colonies, as you can see in the picture below left. That is what Candida albicans looks on a blood agar plate. It looks very much like just a coagulase-negative staphylococcus. There are a few genera of yeast that are capable of producing pigment. You can look over on the far right. That's what's called a rhodatorialist species. This yeast actually has an orange to red pigment. Some genera also produce mucoid colonies, such as Cryptococcus, due to their capsular material. The molds are very different. They produce hyphae and conidia, or sometimes called spores. I will stop at that point and say mycology evolved from the biological sciences, and there's a huge terminology or words used in mycology that are somewhat meaningless to most of us in the rest of microbiology. So I'm going to kind of simplify some of the terms I use. So I will mostly use either conidia or spores to talk about the production on the molds. Now, your molds grow very different than the yeast. Look at the plates pictured. On solid media, the molds are usually downy, fluffy, or cottony. Most molds produce pigment, and the color of the mold can very much help us identify what mold that it might be. Specimen collection and transport. Fungi are very hardy organisms. They're not difficult to grow at all, so we don't need any special requirements for transport media to send specimens to the laboratory. Usually the way we receive specimens is just in a sterile container because you're trying to prevent bacterial contamination from an outside source. Room temperature is usually quite adequate for transportation. If you are going to have a long-term storage before plating, you might want to put it in the refrigerator at 4 degrees centigrade. There's numerous anatomic sites that are appropriate for culture, such as respiratory specimens, tissue biopsies, cutaneous skin scrapings, ocular, sterile body fluids, CSF, blood, and bone marrow. There's some basic fungal media that are unique to the mycology laboratory. One of the ones that's best known is Sabarod's glucose agar, or known as SABS. This is an all-purpose fungal media, does not have any antibiotics in the media. It contains 2% glucose and a pH of around 7. Its best use is for subculture of fungi for identification and susceptibility workup. We used to use it a lot as a primary plating media, but since SABS does not contain any antibiotics, a lot of growth on this media could be mixed, and bacteria could actually overgrow yeast or molds. The next very useful media is inhibitory mold agar. This is both a selective and enriched medium. It contains chloramphenicol and gentamicin to inhibit bacterial growth. This has become one of the most popular primary recovery medias for pathogenic fungi, and for that reason, and for that, all fungi really, very, very useful media, inhibitory mold. Mycocell or mycobiotic agar has a very specific use. It's a selective Sabarods-like medium containing chloramphenicol and cyclohexamide. It is selectively used for the culture of dermatophytes. And of course, those are fungal species that cause skin, hair, and nail infections. This media should not be used as a primary plating medium because the inhibitory agents, particularly cyclohexamide, can suppress the growth of some very important fungi. And this is something to remember. Don't use Mycocell as a primary plating media because the cyclohexamide could suppress Trichosporon species, which is a very important yeast, Candida tropicalis, and Cryptococcus neoformans and Gattii. Brain-heart infusion, BHI medium, with or without blood, is also used a lot in mycology. It is used for the primary recovery of all fungal species. Its inhibition of bacterial growth with addition of chloramphenicol and gentamicin makes it very useful. You can also add sheep's blood to the BHI, and this can nurture for some of the systemic fungi, particularly Histoplasma capsulatum, which likes to grow in the presence of blood. Processing of fungal cultures. When you get your specimens into the laboratory, you inoculate the specimen onto the medium and streak for isolation, as shown in the picture on the left-hand side. After that, it's very important that you seal the plates with oxygen-permeable tape. This will prevent environmental contamination and also protect laboratory workers from plates opening, which could release pathogenic fungal spores into the environment. You could also use tubes or vials that screw shut, but the problem with using such vessels is it's more difficult to visualize fungal growth and also more difficult to insert utensils in there to try to get out specimens to work with. Once we have the media plated, we incubate the media at 30 degrees centigrade for 4 weeks. Notice the temperature for incubation. It is lower than the temperature that you would normally use for bacteria. Bacteria is incubated at 35 degrees centigrade. Fungal cultures should be incubated at 30 degrees centigrade. This will help you, as we will discuss in a few minutes, to isolate the mold form of the systemic fungi. Also, besides the temperature, notice how long you incubate fungal cultures. They just go on forever. We incubate them for 4 weeks. That is the standard of practice. The extended time is necessary for the detection of some of the slow-growing systemic fungi. If growth occurs, then of course you're going to perform appropriate identification test methods. Let's first talk about the yeast identification methods. For years, we've used biochemical reactions to identify yeast. But recent taxonomic updates and new emerging yeast pathogens have challenged the accuracy of biochemical identification methods. So we've moved on to newer methods with improved accuracy of identification. The two most common methods now used is MALDI-TOF and sequencing. In MALDI-TOF, of course, it stands for Matrix-Assisted Laser Desorption Ionization Time of Flight. In this technique, it has absolutely nothing to do with biochemical reactions. The yeast is actually put onto a metal plate where it's superheated and converted into charged protein particles. And based on the mass and charge of these particles, they form identification peaks that are characteristic for each yeast species. The second one, of course, is 16S RNA sequencing. This can be particularly helpful for very rare and difficult to identify yeast species that perhaps MALDI-TOF cannot even identify. This is based on the detection of sequence differences or polymorphisms in the 16S RNA of the gene of the yeast. Mold identification methods. Classically, we have used lactophenylcotton blue preparations for decades to assist with mold identification. And this can still be used in laboratories and is very commonly used at least for the preliminary identification of molds. Lactophenylcotton blue is that staining agent that you see on the picture below. It is a mountain medium that consists of phenol, lactic acid, glycerol, and aniline cotton blue dye. In doing a lactophenylcotton blue adhesive tape prep, it's so simple. You actually use clear adhesive Scotch tape. You touch the mold colony growing on an agar plate, and that will pick up hyphae and conidia onto the adhesive tape. Then you gently press that tape into one drop of the LCB on a microscope slide, like shown on the left-hand picture. You then take it to a light microscope and usually put under 40x, and you observe for hyphae and conidia and any other unique structures that might occur for the mold. This is an Aspergillus fumigatus pictured, and we'll talk more about this in later lectures, but this would be the preliminary identification of this mold. Simple and fast, inexpensive, beautiful. The only problem is the taxonomic changes, and there are so many species of molds now. Sometimes it can only give you a preliminary identification, but still very, very useful information. If you need to have more definitive identification methods, we go back to those two techniques we just talked about. MALDI-TOF offers a library for identification of molds, and you can also use sequencing to help in identification. Safety in the mycology laboratory is very important. All identification work on molds must be performed in a biosafety level 2 biosafety cabinet with HEPA filtration, as shown on the bottom right. Yeast identification can be performed on the benchtop. As I already said, all fungal media plates should be sealed to prevent contamination from mold producing spores being released into the laboratory. So you would take any plate that needs to be examined into the biosafety cabinet. You would then undo the tape from the plate and then open up the plate to do your Scotch tape preps and such underneath the biosafety cabinet. Now let's start talking about the direct examination of different types of specimens and the different types of methods that you can use. Let's talk about the most simple one, which is near and dear to the hearts of all microbiologists, and that's the gram stain. The gram stain can be very useful for looking for yeast cells. They will gram stain yeast cells a bright blue color, as on the bottom left-hand side picture. This is at 100 oil immersion lens. You can examine the stain for budding cells to confirm that it is a yeast and not a staining artifact. Gram stains, even if they're prepared quite well, sometimes will give you some artifact material that could be confused with a yeast cell or bacteria for that matter. So you have to make sure that you look very closely at a gram stain to make sure that it has uniform shape and size and that it is consistent with an organism. So you can see, as I said, the budding yeast form on the left-hand side. In the center, you can see the yeast pseudohyphae. They are also well stained and quite visible. This would be like a Candida species. You can see the branching pseudohyphae with the attached yeast cells. Over on the right-hand side, far right, is a gram stain of mold. If you look very closely where the blue arrow is pointing, I think you can see that there is some true hyphae or mold or mycelial structures in this gram stain, but they can be very, very difficult to visualize. They're very faint. A good microscopist can see them and can use gram stains sometimes to search out mold, but no one would say a gram stain is a good way and sensitive way to look for a mold. This is the old potassium hydroxide prep, or known as the KOH prep. This has been used for decades, but it's kind of fallen out of favor because as you look at this picture, you go, what am I looking at? I mean, they can be very, very hard to observe. So the KOH mount has historically been used to detect yeast, pseudohyphae, and hyphae in skin, hair, and nail specimens. So the KOH will dissolve the keratin in the cellular material that you're doing your KOH prep on, and it will free the fungal hyphae in the yeast cells so they can be better visualized in this type of preparation. The KOH prep is not very sensitive, and hyphae can be confused with cell borders. And so if we look at this KOH prep in the picture, you can see where the yellow arrow is pointing to some fungal hyphae. And it has been freed possibly from the cell material, but there's no staining to it. It's just clear, and it could be very difficult to interpret. And so this kind of prep was very useful 30 years ago, but it's not quite as useful now. Most people have moved and turned to using the calcifluor white stain instead. In this prep, yeast, pseudohyphae, and mycelial fungi will bind with the calcifluor white stain reagent and fluoresce a bluish color, as you can see in these pictures. This is much cleaner and easier to read than the KOH prep. The only problem with doing this, though, is it does have to be read using a fluorescent microscope at 40x. So you have to have a fluorescent microscope available to read these slides. And not every smaller microbiology laboratory could have such a scope. It's generally considered to be more sensitive and specific than a KOH preparation. Next is the India ink prep. This is also kind of old school, but a lot of centers, such as my hospital, we still use the India ink prep to look for Cryptococcus in cerebral spinal fluid. If you run a very high patient population of AIDS patients, sometimes this can be a very useful preparation for the very rapid diagnosis of cryptococcal meningitis. On this type of preparation, you put 1 drop of the black India ink into 1 drop of CSF on a microscope slide. Simply cover it with a cover slip and examine it at 40x. It's a negative staining technique, as you can see on the slide on the right-hand side. It stains the background of the prep, but not the yeast cell or capsule itself. If you look at this picture, you can see that the clearing around the yeast cell is the polysaccharide capsule produced by both Cryptococcus neoformans and Cryptococcus gazzei. Also notice that you're viewing in the center the budding yeast cell of Cryptococcus. India ink is certainly less sensitive than the cryptococcal antigen test for cryptococcal meningitis diagnosis, but it is the cryptococcal antigen test is certainly considered the best test and most sensitive for the diagnosis of cryptococcal meningitis. But the India ink, as I said, can provide a very, very rapid just slide preparation to screen for the presence of this disease. Examination of fungi in fixed tissue. GMS is a very useful stain to look for fungal organisms in fixed tissue. Yeast and hyphae will stain gray to black. This stain will stain both living and dead fungi. The description of the yeast and the hyphae can aid in identification of the organism that might be seen in this tissue. By no means am I saying that you can identify what fungal organism it is, but you can maybe get an idea in which direction you're headed. Is by the width of the hyphae, is it a zygomycete, or is it more of an opportunistic looking fungi? Does it have regular septations? Is there a specific angle of the branching? You can at least get some indication of which way it might be headed, but of course culture becomes the definitive answer to what fungal organism it actually is. You can also observe the size and budding pattern of yeast, and if there is presence of pseudohyphae, indicating more likely that it might be a Candida species. And we're going to explain on later slides and certainly on the next lecture about mycology, how these different observations can assist in identification. Another histopathologic stain that can be used is the periodic acid shift, or PAS. This is positive staining hyphae with PAS or magenta. PAS will also stain structures such as carbohydrate macromolecules as glycogen, glycoprotein, or proteoglycans. So it's not specific for fungal organisms, but it does give you a nice magenta color to fungal organisms. Unlike the GMS that stains both living and dead fungi, PAS stains only living fungi. Mucicarmin or mucin stain can be very useful if you're trying to decide if you're dealing with a Cryptococcus neoformans or gattii or not in tissue. The mucicarmin stains the polysaccharide capsule of Cryptococcus neoformans and gattii a pink color. It can also stain mucin in fixed tissue, so you need to make sure that you're looking at the morphology consistent with a yeast organism. You can observe the pink staining yeast cells in these mucicarmin slides. Another stain that can be used sometimes, but very rarely needed, is a Fontana-Mason silver stain. This detects melanin, which is found in the Cryptococcus organisms. It can be used in the very rare situation when you have a capsule-deficient Cryptococcus organism and you need to differentiate it from other yeast. With this stain, because of the melanin, Cryptococcus will stain dark. H&E, Hematoxylin and Eosin stain. This can be helpful for the description of cellularity in tissue and also the morphologic assessment of size, septations, and branching of pattern of molds, and also the size and budding pattern of yeast. Also, you can visualize such structures seen in fungal disease as sulfur granules. Now, the second part of this lecture will start with the dimorphic fungi, and we will go through all of the most important species of the dimorphics. So let's first start with what is a dimorphic fungus. Well, depending on the temperature and conditions of the environment, you can have one fungal organism which can actually demonstrate two forms. The first form could be the mycelial form. This would be pictured on the bottom left. The mycelial form has hyphae and conidia. This occurs free-living form in nature and growth in the laboratory at temperatures less than or equal to 30 degrees centigrade. The same organism in different situations will be yeast or yeast-like forms. This would be the parasitic phase found in human tissue and growth in the laboratory at temperatures of greater than 35 degrees centigrade. Exposure to the increased body temperature will transform the mycelial form to the yeast form. So a great example of a dimorphic fungus is Histoplasma capsulatum. On the left-hand side, you see the mycelial form that would occur in the laboratory at 30 degrees and in nature with hyphae and conidia. And on the right-hand side, this would be a biopsy from human tissue with the yeast form. Also, if we grew this organism at 35 degrees centigrade, we would grow the yeast form. That defines dimorphism. These are the most common dimorphic fungi that we will talk about: Histoplasma, Blastomyces, Coccidioides and Potassium, Paracoccidioides brasiliensis complex, Sporothrix schenckii complex, and Penicillium marneffii, which has been taxonomically updated to the new name Tayloromyces marneffii. This brings up one important point. I have no clue at what stage in taxonomic updates a board exam might be. And so that's why I have included both names, the old name and the new name, so that you would not be confused on a board exam or in real life reading papers or such things or having conversations about these organisms. Okay, let's start with Histoplasma capsulatum. The epidemiology, it is found worldwide, but in the United States, we think of the major epidemic or endemic area for this fungal organism to be the Ohio, Missouri, and Mississippi River valleys. If you look at the map of the United States on the right-hand side, that is the darker green colors. You can see the shade of green kind of gets fainter as we move out around that dark green. And these are areas in which Histoplasma capsulatum can be found, but in less amounts. So over time, histo has really spread over a much larger geographic area. Where in the environment would you find Histoplasma? It's very commonly associated with aerosolized bat guano, and it's rich in the Histoplasma capsulatum conidia. And so it's very common that infections occur in people that are cave explorers. And these people are known as spelunkers. Another way that you can acquire histo is just having association with bird droppings in the endemic area. This includes chickens as well. And so farmers are known to be one risk group for Histoplasma. 95% of infections are subclinical in histoplasmosis, but 5% of infections are pulmonary with or without dissemination. Who gets progressive histoplasmosis? Usually you think about people with HIV or AIDS. They can have both primary histo or they can have reactivation when they acquire their HIV infection. Organ transplants can have both primary and reactivation. Taking certain medications that are immune suppressive can lead to progressive disease. Infants are more suspect, and older adults, age 55 and older, with both primary and reactivation disease. It is very uncommon for most organisms, whether it be bacteria or fungal, to go to the bone marrow. That's not a very common site of dissemination, but Histoplasma is unique. It's a very common site of dissemination, so bone marrow examination can be extremely useful in trying to diagnose disseminated and advanced cases. Also, Histoplasma has a lot of mucocutaneous lesions in its dissemination forms around the face and mouth, particularly deep lesions into the mouth. Treatment when necessary is itraconazole, fluconazole, or amphotericin. I know you're not usually treating physicians in your role as pathologists, but I do think that as microbiologists and as pathologists, they do, the boards and everyone in real life expect us to know something about treatment of these infections. So I will include a lot of drugs of choice in these lectures. How do we diagnose histoplasma? We're going to talk about culture, but before we arrive at culture, let's talk about antigen detection in urine. This is a very common screening method for looking for histoplasmosis. You look for the antigen by using a quantitative enzyme immunoassay. It is performed on a random collected urine specimen. It's most sensitive, quite sensitive, really, over 85% for the diagnosis of disseminated and chronic pulmonary histoplasmosis cases. It's a useful test in immune-suppressed patients that do not produce a detectable antibody response. Yes, there are capsulatum antibody tests available, but really most of them have been replaced by using the screening for antigen in urine. The culture for histoplasma. It grows, the mold, of course, grows at 30 degrees centigrade, and you can see the picture on the right-hand side. It requires 2 to 8 weeks to grow. So you can see why physicians are very dependent upon you to look at the tissues and also on the antigen screening test, because that's going to supply them information in the first 2 to 3 days, where our cultures are going to be very delayed. When it grows, it's a colony that is white to brown and cottony. The microscopic appearance on the Scotch tape mount is like that picture on the right-hand side. We would describe that as having slender septate hyphae. It produces tuberculate macroconidia. Those are the very large round structures. They are 8 to 16 microns in size. If you look at the macroconidia, they have little spines or little tubercles coming out from them. That's why they're called tuberculated macroconidia. They're kind of like little bumpy projections out from the large macroconidia. That is a structure that's used for the identification of histoplasma. But the very important structure for infection is the microconidia. The microconidia you can see next to those large macroconidia. They are 2 to 4 microns in size. When the mold grows in nature, those microconidia are the infectious particle. They are inhaled and they can penetrate deep into the lung, and this is what causes infection. We can look at these, and an experienced microscopist could probably identify histoplasma based on this very distinctive morphology. But the standard of practice is always to confirm a histoplasma diagnosis from culture. You can use MALDI-TOF, DNA hybridization probes, or sequencing to confirm the identification. This confirmation is very much required, and it's regulatory as well required, due to look-alike fungi that can appear in patient specimens. The primary look-alike fungi for histoplasma is one called Cepidonium species, which is usually considered a saprophytic fungi, and you would not want to confuse Cepidonium with histoplasma. If we grow this organism or this patient specimen at 37 degrees centigrade or 35 degrees centigrade, we're going to get the yeast form. It also takes a very long time to grow, 4 to 8 weeks. The colony is white to beige and creamy in consistency. If you look at the right-hand side, the microscopic appearance of Histoplasma capsulatum is very important to remember. It has a very characteristic size. It's small. It's 2 to 4 microns in size, oval to round, with a narrow-necked budding yeast. The yeast is the form that's found in human tissue. The yeast will be in human tissue, and then when we put it, we can start out in nature. We're going to have in nature, you're going to have the mycelial form in nature. You inhale it, and as these spores are exposed to the higher temperature in the human or in the laboratory, the increased temperature is going to induce the mycelial phase to undergo transformation into the yeast phase. And so that's why we end up with the yeast in the human tissue. Of course, you're going to need to know what histoplasma looks like in fixed tissue. As we said, infection begins by inhalation of the microconidia, and then when infection ensues, you're going to have granulomatous produced. They can either be non-caseating or caseating. From there, they can disseminate from the lung to organs of the reticuloendothelial system. And this is unique to histoplasma. It has tropism to organs of the RES system with high percentage of dissemination to the bone marrow. This is what histoplasma will look like in fixed tissue. Usually the yeast are intracellular within macrophages. Remember, they are small yeast, 2 to 4 microns in size, with very minimal size variation. They're going to be 2 to 4. They're not going to be 2 to 20 microns or, huge size variances. They're going to be round to oval, 2 to 4 microns. They have a narrow neck bud. They're oval to round. And also, it could look very much like a yeast called Candida glabrata. We will discuss glabrata in the second mycology lecture, but you want to make sure that you're looking at Histoplasma capsulatum. One of the things that is different with Histoplasma from Candida glabrata is there appears to be encapsulation due to the staining artifact. Look at the picture in the center. You can see that the cell wall the membrane has pulled away from the cell wall, and there's been a shrinkage of the yeast cell away from the cell wall, and it looks like the yeast is encapsulated. This is why it was called Histoplasma capsulatum. And this is a unique feature of histoplasma in H&E stains sometimes that you can make out, which will very much not look like Candida glabrata. The yeast stains well with a variety of stains. You can see it in a GMS stain, H&E, Gram stain even, PAS, and Wright stain. It is not difficult to stain. Sometimes it can be in numerous numbers, sometimes not. Sometimes you would have to search a tissue to look for yeast cells. I warn you, beware of lookalikes. Tests always love lookalikes and to try to confuse you, and real life can be very confusing as well. The primary major lookalike for Histoplasma capsulatum is Leishmania donovani, the mastigote of this organism, which is pictured on the left-hand side. But please notice the red arrow pointing to the kinetoplast, which is an identifying structure of Leishmania. That kinetoplast will never appear in Histoplasma capsulatum cells and will be an identifying structure of Leishmania. So look for that and look closely before you just jump to a conclusion that it's histoplasma. On occasion, some people think Toxoplasma gondii tachyzoites look a bit like histoplasma. They tend to be a little bit more oval to crescent in shape than the round shape of histo, but they can be somewhat the same size range, and some people might be confused. This would be just a classic slam dunk case of histoplasmosis. 38-year-old male, newly diagnosed HIV, high viral load, low CD4 count. So he's very lymphopenic, anemic, thrombocytopenic. He has bilateral pulmonary infiltrates. You can look at the bone marrow aspiration procedure and see that there are yeast cells present in the bone marrow. On a GMS stain, you can see the very abundant small yeast cells, 2 to 4 microns in size. We grew it in culture, and you can see that the Histoplasma capsulatum grew with macro and microconidia, and he had an abnormally high histoplasma antigen in the urine. Very clear-cut case of histoplasmosis. Of course, there's got to be something weird about histoplasma, so this would be the unusual variant duboisii. This is found only in endemic areas in Central, East, and West Africa. Primary infection occurs in skin and bone. The trick is the mold phase of duboisii is identical to the regular old Histoplasma capsulatum. The trick of duboisii is the difference in the size of the yeast cell, which is found in the tissue. The yeast cell of duboisii is 6 to 12 microns in size, which is at least twice the size of Histoplasma capsulatum. The next important dimorphic is Blastomyces dermatitidis. The epidemiology is found in Ohio and Mississippi river valleys, which does overlap in some of the areas of Histoplasma. Unlike Histoplasma, though, there is no association with any animal or specific activity, such as cave climbing. Blastomyces dermatitidis is associated with forested areas and riverbanks, so it's found in the environment. It's primarily a pulmonary pathogen. Small percentage of patients, though, will disseminate to skin and bone. Dissemination occurs most often in the immune-suppressed patient. The classic dissemination of blastomyces usually has a well-demarcated skin lesion, as you can see in the picture. It has a very, very well-defined edge to the skin lesion. Blastomyces mold will grow in culture at 30 degrees centigrade. It also grows very slowly at 2 to 3 weeks. It's fluffy white and somewhat buff-colored mold and prickly. If you look at the bottom pictures, you can see the microscopic lactophenocotton blue preparation of Blastomyces. It has narrow hyphae septate with a pear-shaped conidia at the end of the supporting hyphae. It looks like a lollipop. There is a look-alike fungus called Chrysosporium species that you can see the picture far over on the right-hand side. One could argue that if you're a good microscopist, it's not that much of a look-alike, but a lot of authorities say that it could be confused. Once again, regulatory and good standard of practice is you must confirm all the identifications from using a lactophenocotton blue prep with MALDI-TOF, DNA hybridization probe, or sequencing. The yeast phase of Blastomyces is very classic in mycology. This yeast grows at 35 degrees and takes up to 4 weeks to grow. It is a very large yeast cell that can have considerable size variation from 8 to 20 microns. It is round to slightly oval. But what's most unique about this yeast is its broad-based budding pattern and its double contoured wall, as I've shown in a very clear picture on the right-hand side. If you look on the pictures on the left and in the center, you can see also that it is broad-based bud, which means the bud between the daughter cell and the mother cell, the neck, so to speak, is very, very broad. And also you can see the double contoured wall in these slides. This is a very characteristic structure and a very important yeast to remember. The histopathology is usually mixed pyogenic and granulomatous inflammation in tissue. It stains well with H&E, PAS, and GMS. One thing to remember is it may stain very weakly positive on mucic harmon and can cause confusion with C. neoformans and gassii. But that's usually a very low percentage and does not occur very often. But it's something to remember. It also has, of course, broad-based budding yeast cells as the classic structure in your histopathology slides. Let's move on to the next organism, which is Coccidioides immitis and Potassium. Of course, we used to always think just about Coccidioides as being Coccidioides immitis. But of course, the taxonomists had to get to work, and they realized that there were two species that were sharing very close genetic relatedness, and they're found in different regions of the United States. And so they reclassified Coccidioides in two separate species, Coccidioides immitis, which is primarily found in California, and Coccidioides potassium, which is found outside California. They have identical disease processes and react the same in serologic and morphology-based diagnostic tests. I'd have to say, for the most part, most laboratories would not care about the differentiation of the two because, as I say, they're virtually identical in every way. Coccidioides is endemic in the southwestern part of the United States, known as the San Joaquin Valley, Mexico, and South America. All of these areas that are high in cocci endemic area are also known as Sonoran life zone. They have warm and desert sands, like pictured on the two bottom pictures on the right-hand side. The way you get infected from cocci is you inhale the fungal particles known as arthrochonidia that are found in the sandy soils in the Sonoran life zone areas. So your casual stroll through a breezy day in the Sonoran life zone areas would perhaps be an introduction into cocci disease. 60% of the patients that acquire this organism in their lung will have asymptomatic infections, but 30% of the patients will have limited pulmonary disease. Unfortunately, the remaining 5 to 10% could experience chronic disease, progressive pulmonary, or very serious disseminated infections. Cocci in its disseminated form has a tropism to the central nervous system, and this carries a very high fatality rate. Risk factors for severe or disseminated cocci include African American or Filipino race, HIV/AIDS, use of immunosuppressive medications when you acquire your infection, organ transplants, diabetes mellitus, and pregnancy. You can use serology techniques to diagnose cocci. It is one of the fungal diseases where the serology is fairly well defined. You can use enzyme immunoassay, or EIA, which is a sensitive and commonly used method for diagnosing cocci. It can detect both IgG and IgM antibodies. Immunodiffusion can detect IgM antibodies, which can be found early in infection. You have to watch out for the sole use of immunodiffusion as your serologic test. It's not as specific as the EIA for detecting antibodies, and you can get false positive results. So you need to confirm a positive immunodiffusion for IgM with a enzyme immunoassay test. There's also complement fixation tests that detect IgG antibodies and allow for assessment of disease severity. Cocci can be grown very easily in all areas of the laboratory, which is both good and bad. Cultures grow, of course, at 30 degrees, and they grow rapidly at 2 to 3 days. This means that you could pick up cocci on just a regular respiratory culture in the microbiology laboratory. So we have to be very cautious since we are in an endemic area. I'm in the Los Angeles area. So we grow it in 2 to 3 days. Hopefully it grows in one of our sealed fungal plates, and it becomes woolly in around 7 to 10 days. And you can see the progression on the pictures on the upper right-hand side from rather waxy colony at 2 to 3 days to its fully woolly and conidia-containing form at 7 to 10 days. If we make a microscopic lactophenol cotton blue prep of that mold at 7 to 10 days, we will see the microscopic appearance on the upper left-hand side. This is at 40x objective, and you can see the septated hyphae, which what are referred to as thick-walled, alternating barrel-shaped arthrochonidia. And whenever you hear that explanation, that term, those terms I use, thick-walled, alternating, barrel-shaped arthrochonidia, that's your description of Coccidioides. Notice that it's not just broken off into pieces. They are kind of enlarged and more in barrel shaped. Also notice that most of them are alternating, and that's because the barrel shaped darker ones are alive and very capable of breaking off and causing infection, where the areas in between have died off. Beware also that a mature culture, such as that 7-day culture pictured, is a very big biohazard in the microbiology laboratory, and this is one of the reasons why you must be very cautious and take all molds into the biosafety cabinet to make sure that molds are not released into the laboratory. There are cocci lookalikes. This is Malbrachia species that can appear similar to Cocci immitis and Coccidioides under the microscope using a lactophenol cotton glue prep. So like with all of our other fungi, you must be have a confirmatory method using MALDI-TOF, molecular probes, or hybrid or sequencing. Cocci histopathology. There's no yeast cell produced in human tissue. What? Yes, let's back up again. There's no yeast cell produced in the human tissue of Cocci. Instead, the dimorphic form for Cocci is a thick-walled spherule, which can be variable in size. They can be 10 to 80 microns, and when they're in their mature form, they will have endospores. So look at the picture below. You can see empty ones, one that is releasing endospores, ones that are formed with endospores within. So you can see all different stages of development of these spherules. And they will produce mature cysts and then produce the very small endospores, 2 to 5 microns, that can be released from these spherules, and they can set up and form new spherules. Usually you're going to see granulomatous inflammation with caseation. Please notice on the left-hand side, on the bottom, I have something in red there, saying that the position of Cocci spherules can sometimes mimic the broad-based bud of Blastomyces. So when you're looking at patient specimens or you're rushing through a board exam, be very cautious. Look at the entire slide. Do not jump to conclusions. Sometimes there can be little things that can throw you off. This would be a very good just case history of Cocci. 75-year-old male with a right pleural effusion. You can see the beautiful GMS stain of both a immature and mature spherule of Cocci. He had gout, hypertension, anemia, and obesity. His fungal serology, his histoplasma urine test was negative, cryptococcal antigen negative. The Cocci IgM was indeterminate, but he did have Cocci IgG titer. He lives on a ranch in Simi Valley in California. This is prime Cocci territory for our area. And you can see the culture grew the barreled arthroconidia that is characteristic of Coccidioides. Beware, Coccidioides is not the only spherule-forming organism. Rhinosporidium seaberi is an aquatic parasite, and it can form spherules that are larger than those of Cocci and can appear in tissues in real life and on boards. Rhinosporidium spherules can be greater than 80 microns in size compared to those of Cocci. Cocci is usually less than or equal to 30. Rhinocerebri causes oral or nasal mass lesions, not the disseminated, horribly fatal diseases of Cocci. Prototheca rickorhemi can also produce structures known as morulas that can sometimes be confused with spherules. Morulas are mostly seen in skin lesions. So just beware of these look-alike structures. Paracoccidioides brasiliensis complex. This is South American Blastomycosis. Most of your infections are reported in Brazil. It is your most prevalent systemic fungal infection in Latin America. And of course, like all of these, infection is acquired from inhaling the infectious particle from the soil. Most infections do occur in males, possibly due to estrogen inhibition of the fungus transformation from mycelial to yeast. The disease presentation is primarily of pneumonia. Dissemination can occur, and if it does occur, a lot of times you'll get extrapulmonary lesions on the face and oral mucosa, as shown in this picture. Paracocci does grow as a mold at 30 degrees, but in countries that are endemic for Paracocci, they usually don't fool with growing the mold because it's really non-specific in sporulation, and you're not able to identify it. By far, the yeast is the most characteristic structure of Paracocci. It's a slow-growing yeast, takes about 3 weeks, very large, 10 to 30 microns, thick-walled with 2 or more teardropped daughter buds. Look at the picture. It is one of the most unique yeast that we see in mycology. It's known as the mariner's wheel or pilot's wheel yeast. Take this in and remember this yeast is a very characteristic structure in mycology. The mariner's wheel or pilot wheel yeast. It is the only yeast that's going to have 3 or more buds present. The tissue exam will also show multiply budding yeast. It will have granulomatous inflammation with giant cells formed in tissue. Sporothrix schenckii complex. This is sporotrichosis. It is cutaneous inoculation from a penetrating injury, such as a cut or scrape with contaminated plant thorns. It is oftentimes known as the rose gardener's disease because the rose bush has such prickly little spines on it and is oftentimes a source of injury. It usually begins as a skin lesion, as shown in the bottom right-hand picture, with or without ulceration. And then this leads to a subcutaneous type infection. The lesions can progress with a lymphocutaneous spread, like shown in the left-hand picture, and possible dissemination to bone and other organs. Pulmonary and CNS infections have also been reported, but they're really somewhat rare. Sporothrix schenckii complex mold grows at 30 degrees, easy to grow at 3 to 5 days. It starts as beige and eventually turns brown to black. If you do a lactophenol scotch tape prep of this mold, you're going to see thin septate hyphae with conidia in a daisy wheel or rosette pattern. And that is usually the word used to describe Sporothrix. The yeast will also grow in around 7 days as a small oval and elongated yeast cell. It is one of the few yeasts that we see in mycology that is described as cigar-shaped or cigar bodies. It's about 2 to 5 microns in size. Sporothrix schenckii histology is pyogenic to granulomatous inflammation. The yeast cells are seldom observed in human tissue. That's very frustrating. But if they are seen, they're elongated, pleomorphic structures described as cigar-shaped. The picture shown over on the right-hand side would be such a structure seen in tissue. But more commonly, you would see a structure known as an asteroid body or a Splendor-Hopley phenomenon, as shown in the picture in the middle. That is a picture of the asteroid body. The Splendor-Hopley phenomenon are not unique to sporotrichosis, but seen very commonly in this infection. It is also seen in other fungal infections such as Mucormycetes, Aspergillus, Blasto, and Candida species. Also notice the GMS staining of the Sporothrix schenckii organism. It can be pleomorphic, but the predominance of the yeast are long, elongated, and cigar-shaped. Finally, we come to Penicillium, or Tailoromyces marneffii. This disease causes most often cutaneous bumpy lesions, the disease known as Tailoromycosis, which is most common infection, but you can also see pneumonia or systemic infections, which can mostly occur in immune deficient or HIV/AIDS. The most common infection is found in Southeast Asia and southern China as the cutaneous lesion shown in the bottom right-hand side. These organisms are found in the soil, and that's the way the infections occur. The mold grows in 2 to 3 days as a green colony with a red diffusible pigment. Microscopically, if you do a lactophenol cotton blue prep of the penicillium, it looks like any other penicillium that you're going to see as a bred mold or in infection, with a branched conidiophore and sporulation in culture. This is what it would look like at 30 degrees centigrade. You can see the red diffusible picture in the in the picture on the left-hand side and what the mold phase looks under the microscope. Looks somewhat like a bony hand. If you look where the blue arrow is, and which is the fixed tissue, you can see what the penicillium looks like in a fixed tissue slide and see that it is truly dimorphic. In fixed tissue, it's going to be a yeast-like structures. And so that is what the penicillium or nephii will look in its dimorphic phase. That brings us to the end of our first lecture on mycology, and we've completed the dimorphic fungi. I hope you gained something from listening to this lecture, and I look forward to joining you again in the next month or so with the second part of mycology. Thank you very much for joining me today.
Thank you so much, Dr. Morgan, for this excellent discussion on dimorphic fungi, and of course, the first part of it. So I can see a couple of questions online. One question is coming from Proy. The question is, can Candida glabrata be confused with Candida albicans?
Well, Candida albicans, you mean in fixed tissue, I assume. In fixed tissue, Candida albicans can often form pseudohyphae, which Candida glabrata cannot. And Candida albicans is normally 6 to 8 microns, more usually 8 microns in size, compared to the smaller glabrata at 2 to 4 microns in size. You have to learn the characteristics, but as you learn them, I do not think you would confuse the two.
And the next question is, is Grocott a modification of Gomery?
I'm sorry, can you run that past me again?
Is Grocott stain a modification of Gomery stain?
Oh, yes. That's a good question. I'm not a histopathologist, and I can look into that to you. I would assume the answer to that question is yes, but I do not have a firm stand on that one.
No, thank you so much. So thank you, Dr. Morgan, again for this excellent lecture. And if any viewers have questions, you can reach out to us or you can write to Dr. Morgan. Dr. Morgan will be more than happy to answer your questions. And Dr. Morgan, you will be happy to hear that you had several hundred viewers from different parts of the world. It must be quite late somewhere else. And you had viewers from as far as Bangladesh, Saudi Arabia, Bolivia, Costa Rica, Nigeria, Tanzania, and of course there were viewers from US as well as from India. So, and the second part of the talk is coming up on August 14th. So please stay tuned, and that will also be at 12 p.m. And we also have a podcast lecture coming up on Thursday, that is July 16th. So that would be on introduction to grossing specimens, and our speaker is Dennis Strang, who is a pathology assistant at Wisconsin Diagnostic Laboratories. And with new trainees that we have across the US, I think this would be a good way to get oriented about grossing in the anatomic pathology laboratory. So with that, thank you so much again, Dr. Morgan, and we appreciate your time and effort. Thank you all.
Thank you very much.
Thank you.